Hey folks, Scott Weingart here, and this is a joint podcast between the EDECMO podcast and the EMCrit podcast. What you're going to hear is a grand rounds recorded during our Reanimate 5 EDECMO and ECPR course in San Diego. And R5 was easily the best we've ever been a part of. Joe, that's Joe Bellezzo, Zach Shiner, and Chris Ho, and I had a conference that exceeded all our expectations. And the guest of honor for this conference was Demetris Yannopoulis. You've heard him on the EMCrit podcast. You've heard him on the EDECMO podcast. He has been doing incredible ECPR work in Minnesota. And this lecture was just phenomenal and inspiring and made me incredibly jealous. And I think it will do all those things for you. The reason we are broadcasting it on both the EMCrit podcast and the EDECMO podcast is because we are using it to announce ticket sales for Reanimate 6 in San Diego, January 31st to February 1st, 2019. These tickets sell out exceedingly quickly, so you want to get on it now. What happens is everyone waits until the last month, and then they're super surprised when we sold out of like the 2 tickets remaining by that point. So if you want in, you should buy now. So here's the site, reanimateconference.com. And with that, let's get right to it.
Welcome to EDECMO.
Welcome to EDECMO.
Welcome. This is EDECMO.
Good afternoon, and thank you for having me here. It's a pleasure to be and an honor. I have some disclosures to make before I talk about all these things. I do have grants from the National Institute of Health, and I also received the charitable donations from the Helmsley Charitable Trust. So just want to make sure that you understand my opinions do not reflect the opinions of the institutions that have funded me. I have to say that, and we're good to go. Okay, so I'm going to start talking a little bit about, everybody knows about cardiac arrest. It's a big issue in the country and all the advanced societies where people live long enough and they have coronary artery disease to die from it. So I will focus on refractory VF arrest mainly because I think for about 70 years we've been trying to do the same thing and hope for different results. You have seen a lot of studies that they come and go, they are negative. And in my opinion, the major reason for that is that no one has ever addressed the primary root cause of the coronary artery disease. And it's only until recent that technologies have been advanced so much that can be used to save people even very late into this cardiac arrest continuum. So we started, I'm not going to talk about resuscitated patients, but we know from resuscitated VF patients that a lot of coronary artery disease does exist in the VF population, both from people that died and went to the morgue and they found I had a lot of blocked arteries, and also a lot of people that they have come to the cath labs in different pockets in the world, and we did diagnostic angiograms. And so the question is why some of these people, the same age, the same characteristics, can have pulses back with a couple of shocks, and some of them never get pulses back. And what is it, the fundamental difference between them? So I have hypothesized over the last 7 years, before I start having the program I will share with you, that these people have so much coronary artery disease that no matter how good your CPR is and how much effectiveness your shocks have, you will never be able to restart the heart. Because CPR will not be able to produce enough blood flow to re-energize the heart with ATP. So I'll start to give credit to the Australian guys and colleagues of ours, that Stab and Bernard, that basically they took a few patients, about 11 patients that they had out of the hospital cardiac arrest, and they tested the hypothesis, if they do have refractory VF, how about we put them on ECLS, ECMO, get them to the cath lab to identify coronary artery disease if it's present or not, fix it if we can, hypothermia, and hopefully they can survive. So you can see here they took 11 patients. Some of them had ROSC. As any early transport, you will find some people have pulses before you put them on ECMO, but it's the intention. So you have about 5 out of 11 survive. It's a small cohort, but it was, I think, one of the first. At the same time, before that was published, we started to organize ours. So people started thinking along these lines in parallel. In the United States, it's much more complicated, as you know, because of issues of mortality, cath lab mortality, a lot of administration, and very large difficulty organize pre-hospital care to be smoothly transferred into the in-hospital arena. So the 2015 guidelines basically says that obviously there were no randomized trials, and if you do have the capability to provide somebody with ECLS, you should consider it as an option in viable patient. Now that is a very vague statement, right? So my job here today is to show you what we have thought as a system of being a good selection process and protocol to have decent results and gain experience in this very, very, very futile population. There are no randomized trials. This is from our laboratory that was published in the Journal of American College of Cardiology, which shows the role of epinephrine and ECMO effectively for refractory ischemic ventricular fibrillation in pigs. And there are a lot of things that you cannot really do and get ideas in patients, right? It's impossible actually. So this is a very clean model simulating exactly our protocol I'll show you, but it shows what is the effect of ECMO. So this is an LAD occlusion. There you can see a little piggy there, balloon, and then they have a heart attack. This is the most common reason that people fall down and have VF arrest, as I'll show you. Both our group and the French group in Paris showed the same results for coronary artery disease prevalence in this population. So for 45 minutes, these animals get CPR and shocks as appropriately, but then we randomized them to get epi or no epi, and then we got ECMO versus take them to the cath lab, open the artery, and hope they're going to resuscitate. So what we found was that if you receive ECMO, you have 82% chance to survive short term. This was not a neurological intact survival, it was just survival. And if you don't have echo, you have 30% survival. And epinephrine, despite the fact that it improves blood pressure and coronary perfusion pressure, animals tend to do worse. So what is the importance of having animal experimentation when it comes down to making decisions in critically ill situations? First of all, it gives you an idea of what is really critical, what is really needed. So this is our model, so you can understand that is very, very useful. This is a patient's angiogram with an ostial LAD occlusion because of a heart attack. And this is an animal that this is LAD. Obviously they're flipped because they're quadrupeds, but effectively we block the artery right there. So this angiogram and this angiogram have exactly the same large area of ischemia, and they respond very, very similarly. But before I start talking about ECMOs and cannulations, I want to make sure that my message is very clear, and all my efforts have focused on that as well. Resuscitation for cardiac arrest is a system approach. Just because you have a cannula and an ECMO and you know how to put cannula, you don't have a program. And the reason I'm saying that is the delivery of the patients to you and the quality of perfusion before arriving to any center is the most important critical determinant of their survival. So this is two different CPR studies. So this is standard CPR in animals, and you see over time of CPR up to 60 minutes of CPR, and then what you see is lactic acid building up. Within 30 minutes, your lactic acid has gone above 10, and 45 minutes above 14, and many animals up to 20. Okay, so if you have a better quality CPR, and I'm not going to explain exactly what is this, it doesn't really matter. It's a better quality CPR to generate more blood flow during that period of time. This is an experimental CPR method that we'll be testing in people the next 2 years. It's called sodium nitrite enhanced CPR. So instead of epi, we give sodium nitrite and a couple of mechanical means. And you can see the lactic acid never rises above 8. But then we can survive 7 animals, resuscitate them fully, versus only 1 in the control group. So blood flow before arrival truly matters. So you have to work together with your EMS to have a protocol that is fast delivery of care and also very good quality of CPR. So why am I stuck with VF? And whenever you start a program, it's very hard. You want to do the right thing, but this is a very expensive technology. A lot of resources go into it for from manpower, financial resources, and just the craziness of running to do something so quickly. It takes a huge toll to everybody's system, its psyche, and it's a very, very expensive overall program. So in Minnesota, as the medical director of the MRC, I have data, all the cardiac arrests go in database that we share with the Department of Health. And you can see here, out of 7,500 cardiac arrests, 2,400, like a third effectively, is VF. But they do contribute about 85% of our survival. And this is a little higher in Minnesota than the average national, which is about 60-65%. VF contributes to, but also VF is much less as a percentage to other rhythms in the nation. We get a little earlier, who knows why, but we have about 30%, 32% VF, and the national is about 24-25%. So regardless, the largest proportion of your survivals will come from VF. And they are viable. So what I'm going to say is that this protocol that I'm going to share with you is that all these people in general have been left for dead. People that don't get pulses in the field are left for dead. So out of the 2,400 patients, immediately 1,100 patients would have been left for dead in Minnesota over the last 6 years. And even from people that arrive in AD, if you don't have ECLS, about 30% will die before they get admitted because they rearrest or because they're so sick that no one actually is going to pay attention to what they need to happen as futility sinks into the realization of the disease. So the first paper we published was the protocol about almost 2 years now, a year and a half now. Something like that. Time flies, I'm sorry. And basically we described the protocol. Well, I'll share with you. And subsequently, this is the major paper of 1 year outcomes that we describe the proof of the hypothesis that the majority of people with refractory VF do have critical coronary artery disease. And unless you reverse a cause, that is the reason that they're staying into refractory VF, you effectively have no chances to be successful. So how do you do that? So this is the protocol that, with the help with Mark Conceraro, RJ Frasconi, Keith Wesley, and Charlie Lick, in the Twin Cities, 4 EMS directors, good friends of mine, as also working with us very close with the MRC, decided that we're going to change the ACLS process for this population. There was no more, this is what used to happen, so advanced cardiac life support, and they had to have either pulses or they were declared dead in the field. If they had pulses in the field, they would get hospital admission and then about 15% survival. The denominator is, the survival is over-optimistic, I'll show you, because we, in the database, we could only find out who had amiodarone. So amiodarone is considered to be refractory VF. But as you all know, everybody has VF and get a shock, and then they have a couple beats later of VT, they will get amiodarone, and they might be talking to you. So one of the issues here is that it's not the same sickness protocol, and I'll share with you some of this information later. But effectively, then we take them very early to be transported to the cath lab directly after 3 shocks and an amiodarone infusion, and then we put them on ECLS, find out the artery, fix it, and we had 45% survival rate. So the protocol inclusion criteria were chosen not because obviously we have, people ask me, why do you choose that cutoff and why do you do this? Well, we had to start from somewhere. And although common sense sometimes is wrong, in these cases is what we want to have some acceptance, both from all medical people that work in the protocol. So administrators, nurses, cath lab people, EMS, everybody had to feel that there is some rationale behind these choices, which I think, if you look at the early transport criteria, everybody who's 18 to 75 was moved. If you don't know the age, kind of how old they look. We did not transfer anybody from nursing homes, so that is an exclusion for us. But then they had to have received 3 MS shocks unsuccessfully and received amiodarone. At that point, they would call a number and we'll activate the system. They will come directly to the cath lab. They do have to have ability to have Lucas on. If the body is too big or too small, we had a couple of patients that had chest disformities. One had pectus excavatum, and the Lucas would not work. We brought initially young people, we brought them in, but the CPR is so bad over an hour of CPR that eventually you have no chance to survive those people. And then we also needed some time kind of idea. So from the transfer time should be less than 30 minutes, because after that, by the time you go out, you assess the patient, you do this, and then you transfer them to ECMO, it's already past an hour. So if it's consistently past an hour, the outcomes are going to be bad. So in order to have a protocol, you have to remember, you have to be able to identify very quickly people that meet the criteria to be transferred to a place or an ECMO machine can come to them, whatever the process is. You have to identify them early, fast, and consistently, and we had to move them. So then the question is, when they arrive at you, have they been receiving adequate CPR, that you have any chances to perfuse and survive the brain, which is probably the biggest question about this, right? So again, arbitrarily a little bit, but I have been doing animal and human research in resuscitation since 2000. So knowing what perfusion does to the pH and LCO2 gave me a little bit of an understanding of what I could consider reversible and what I could consider irreversible. None of these parameters here, once they arrive into the cath lab, we get a blood gas. If the PO2 is low or the serum lactate is more than 18, we don't go to cannulation. But there are some exceptions. If they're very young, as I'll show you, we do everything we can. Now, why is that? It's just very difficult emotionally to make a decision based on an arbitrary number that you chose not to go ahead and try to save a very young person's life. So if they don't meet any of those three criteria in general, we do the angiography, we put them on ECLS, and we do PCI whenever it's needed. And then we never admit these patients unless they have organized rhythm. If the patients don't have the ability to organize the rhythm after 90 minutes of normalization of perfusion, acid-base balance, and electrolyte abnormalities, that means that they are very, very sick. So we don't admit those patients. So this is the paper that was published in JACC, and it refers to 72 patients. As I told you, we exclude some of these patients because they arrived with manual CPR. As you know, any emergency, you have no information, things are going very fast. Somebody had terminal cancer, somebody was 80, somebody had 90 minutes of CPR. From those 62 patients basically met the criteria to go to the cath lab and get the full SPA treatment. So we got 5 people out of this 55 had pulses on arrival, which is a good thing, and 50 patients were placed on ECLS, 47 patients were admitted to the ICU, 8 were declared dead because they didn't have organized rhythm. So you see, forget about this. You can have an optimal system and still will have some not protocol violations, but inappropriate arrivals to anywhere, right? Because it's an emergency situation. But even after you have the good population, you will have people that miss out, either because of low perfusion or because they are so sick they will never be able to recover their organized rhythm. But then you can pick your denominator and you can decide your survival rate. I report within the protocol because our intention is to treat these people within the protocol. So the middle column is what I claim as survival. My administrators in the hospital care about the right column because it's who you admit for their survival. And so if you see, based on those criteria, who we admit and who, we have about 60% survival in the admission population and about 45%, 42% with the protocol population. Now, these people are in general young. The average age is 50 to 55. They don't have known coronary artery disease as you would be thinking, but they do have a lot of coronary artery disease they don't know about. The majority of them receive bystander CPR. We have a high bystander CPR rate in Minnesota, especially because when they call and we send dispatch, they have dispatch-assisted CPR in progress. The CPR quality varies, as you can imagine, but they do have it or report it. The times are quite fast for arrival, but because the EMS systems that we collaborate are far away, the average arrival to the cath lab is about an hour, 55. Now it has dropped down to 52 minutes over the last year because we expedite the process. We move after the second shock, so we saved about another 10 minutes. But I think what's important also is that we can place the cannulas very, very fast, and I'll show you some of this. And the reason for that is because we use it as, well, we've done a lot, and we basically try to use it in a way like a pit crew would do it. Everybody has a role and everybody's trying to do one thing. And so what matters? The usual things. Time is equal to brain function, to heart function, and also survival. So the faster everything happens, the better it is. End-tidal CO2, a marker of distal perfusion, distal tissue perfusion, and oxygen exchange in the tissues is good. Too high is very bad. I'll show you later why. Lactate, the lower the better. And you see survivors tend to have that magical 10 to 12. If you go above that, the probability for survival decreases. But none of all these things can be used as an exclusionary criteria. So don't take this and say, well, I will never do this something on a patient that has a pH of 6.6. So I've done patients with 6.6 because they have respiratory acidosis. CO2s are very high because they're hyperventilating, but the true metabolic acidosis is not so high. So you have to use your mind. This is not checkbookish. It's like everything else you do in medicine. You have to use your thought process to try to assess the issue. This is, I think, a very important message, and I think it's going to become more prominent over the last few months, the next months, because of an HA statement that's coming out to address those issues, and a lot of publications that are seeing the light. I'll show you two. This is our paper showing that 84% of these people have significant coronary artery disease. Look at these 2 vessels 26, single vessel 30, 3 vessel 44. The main culprit vessel is proximal LAD. Left circumflex and RCA about half, and 9% of them had prior bypass, 33% had chronic total occlusions, meaning chronic obstructions of coronary artery disease that there is no blood flow, zero blood flow down the vessel for a long period of time, and there is acute thrombotic lesions in 65% of these patients. And the syntax score for the surgeons, I don't have a surgeon here, and the cardiologist is high, moderate to severe. You would, most of these people, if they had an angiogram and they had angina, they would go for bypass surgery. That has been corroborated by our French colleagues recently, by Lionel, who's probably here, right? Tomorrow or something, yeah?
Later this evening.
Yeah, so they publish exactly the same thing. 30% have 1 vessel, about 25% have 2 vessels, and about 15 3 vessels. And what they found, LAD, again, it's the same, 80 to 80% LAD, and the same, about 30 to 40% circumflex left and right. So as you see, this is not just Minnesota data, it's also French data. Maybe we eat the same kind of food. I doubt it. But but that's the way it is. So this is not any more disputable. I mean, anybody can say whatever they want, but unless they have data to disprove us, they can argue with themselves at this point. And the reason for that is this is not cherry-picked patients. Every single patient goes to the cath lab. I didn't choose who's going to go to the cath lab. They all went to the cath lab. So that is very powerful because you have a population. It's very well defined what it is. The F, age group, done. And then you take them to the angiogram, okay? What do they require? You see here. The majority of them get ECLs and they get some balloon pumps and coronary stents, so we can talk about that if you want further. But the difference between the two protocols is if you take all the population, the historical control, and then the new population in JACC, we published in JACC, you see that in order to move to the hospital, you have to have pulses. We did not need to have pulses, so only 8% of our people had pulses on arrival, but we admitted almost 80% of them because we didn't need pulses to be admitted. We had ECLs. And obviously here in the other method, the standard of care, which is performed in the whole country, effectively you have this drop because some more people die here in AD, and then some more people die into the hospital, and then basically you end up with 26 people out of 170. And here we admit more, some of them drop, and then we have 26 out of 62. So the difference is we don't let all these people in the field as dead, and that leads to the increase, and I'll show you. So in the community, and this is some data from other investigators, if you haven't had pulses within half an hour, you're done. All your survivors are basically collected within 30 minutes. In the best case scenario, if you arrest in front of paramedics, and this is from the RACC investigators database, 100,000 patients, the probability of survival with time, with VF, is great. If I drop down here, you better save me with a shock, right? And I probably have 90% chance to survive this. But as time goes by in front of official people that know what they're doing, your chance for survival within half an hour is below 15%, and within 40 minutes is like 8. And that is the best case scenario. This is from Japan. 500,000 cardiac arrest reported in resuscitation. The probability of survival with VF, if you're less than 75, with duration of CPR. But this is not 60. This is single digits. Okay, so I would say different system, different population, but the reason I'm showing this is because I want to see how quickly the probability of survival decreases over time. Within half an hour, they go to like undetectable. I don't know who survives. Okay? And this is what happens in the nation. When EMS arrives, it's time 0. So people that receive CPR upon EMS arrival and the duration of CPR over time. This is VF. So if your paramedics on average arrive 7 to 10 minutes post 911 call. In Minnesota is about that, 7 minutes. So whatever you see here is plus 7 minutes from 911 call. Within 30 minutes here, you are less than 15, and within 30 minutes, you're less than 10. Now, this is where our protocol comes in. On average, we receive patients after 50 minutes, and that's why our survival is about 40%. But we do have a scatter of times with earlier and later arrivals. And this is our current survival mode. If you arrive within 35 to 40 minutes from 911 call, your probability for survival with our current protocol is about 80%. And if you arrive after an hour, it drops below, and obviously it doesn't plateau here, it keeps on going to 0. Okay? So there is some credit to be given to our French colleagues that they realize that time is muscle. They have very different problems to solve, and I have my scientific debate about if that's the best way, but I think the best way to do this is a way that fits your system, that you have a lifeline at 30 minutes. If you have failed to resuscitate with half an hour and you meet some criteria, you need to have a lifeline. That lifeline exists currently, but you cannot implement it alone. You need to have a system that can do it. So this is within our own system, the effect of 911 call to ECLS on survival. So if no one comes with less than 30 minutes, right? So 30 to 40 minutes and 40 to 50 minutes, look at this, and then it reverses. Blue is good, survivors. Red is deaths, and green is brain deaths. As time goes by, after 40 to 50, 60 minutes, you see the very nice distribution, right? This is like textbook distribution. And then the problem is, as time increases to put ECMO, you have more deaths and more neurological injury. But that's what happens in the cath lab. The cath lab becomes a trauma bay, and effectively that is counterintuitive to every interventional cardiologist in the country. The reason for that is we are very meticulous, very clean, and we are very afraid of anything that can happen, although truly, and actually in the hospital, cath labs are now considered to be part of the ORs, so we cannot wear specific hats and this and that. It's kind of insane. I've been doing this for 20 years and I really don't know if I've seen a single infection because of an angiogram, okay? But that's one of the bigger hurdles that you're going to have to consider if that were to happen with them. Okay, but no matter what, everybody's waiting, they know what they're doing, there is an ultrasound, and I'll show you, and then within 2 to 3 minutes from door to needle, this has been achieved. And this is a little video that I will play to you. Okay, we don't need to have, it doesn't matter. You can, I don't know, there you go. So the reason I'm stopping so I can explain what we're doing here. But effectively here, the patient came in, 3 minutes later, we're ready to perk. We use ultrasound, we have the fluoro machine available, the Lucas is going on. The patient, there is a valve here, it's called the inspiratory threshold device, a rescue valve, and then it's connected. We got access already, usually vein and artery and vein. We use 2 extra stiff amplas wires, and we'll talk about that probably tomorrow. The reason we do that is because you need a lot of force to push these cannulas fast. And I always nick the skin with this little blade, and I blunt dissect with my finger. There is 2 needles. You don't want to be looking for needles in that. 2 needles, 2 wires ready to go, one next to the other. It's simplified. The tech knows exactly what to do. We open the cannulas. And, a lot of people, you're probably going to do that tomorrow, but no matter what you guys say or anybody says, I have done probably 200 of those in my career so far. It's hard to get access with ongoing CPR, especially on these patients with this thing moving. You have this thing moving and you have the belly coming in your hands, and if you miss it and you screw it up, it's game over. And it's not, I'm not trying to make it such that it's hard. It's doable. Obviously it's doable. We've done it. We have very few complications and it's trainable, but you should not poo-poo it as being something really, okay, anyone can do it. No, anyone cannot do it. And you need continuous training for this and experience. And you either do it in simulation labs but what I have been arguing for the last year or so, which I'll show you later what we're trying to do, is that an expert team needs to be available to do that. Like even if you're interventional cardiologist, we had 6 when I started the program. I was the only one doing it, and now there are 3 of us doing it after they've done 100 of them with me. It's not something that you just, I did interventional cardiology fellowship, I can do this. Because it's not the case. So the other thing that's useful for us, and it's debatable, but I like it, and allows the time to be very fast, and you don't have to worry where things are, is fluoro, because I can verify that my wires are where they need to be, then I don't worry. I can push and I can get a feel of where these things are going. So at this point, also I always put in the venous cannula because the vein is below the artery. And I found initially, at the beginning, when I put the arterial cannulas first, I had a hard time putting sometimes the venous, just because the big cannula was sitting in front and squeezing the vein underneath. And so I always now go with the venous cannula first. I don't know if it's scientifically proven that's better, but it's my personal opinion. So after this point, you see, it's quite stable. We are at 4 minutes, and we are cutting, and the circuit is always primed. The other thing that we found, you see this little pair of scissors that sucks? We had to buy scissors because those regular cath lab scissors do not cut. If your life depends on it, you're dead. So we had to buy scissors for the cath lab to do just that job. So you find all these little things that you assume things would work, but they actually don't work, and you have to fix them. So we are on ECMO, so So that is the other part that a lot of, when we train, people have a hard time. It's, for interventional cardiologists are used to finesse and not force. That brute force of putting these tubes together, it's very uncomfortable. They don't know if they're doing something wrong, and then many times when you put this in, as you already know, you have all these bubbles in that moment that is created and cause a lot of trouble. So there is, we can talk about another time more specific how we do this, but then this is 4 minutes and, so 4 or 5 minutes and the patient is on ECMO, okay? So this is not, yeah, and the reason I'm nodding here is because my colleague, Bob Newmar, never believed that we can do this. You say you're exaggerating what you can do. And he was visiting for another project and this happened and he came and took video. I never had a video before to prove him wrong, so he did it for himself. All right, so these are some cases. The reason we use ACLs is because it's a very stable situation. This is a patient that had spontaneous LAD dissection. You can see the LAD dissection here. She was driving, she had a car accident, she basically tried to be resuscitated. She came to the hospital. We didn't have ECMO that day. All our 10 machines were taken. And so I just did it with ongoing CPR. As you can see here, this is a thread. She received about 52 shocks and none of them brought him back. Once we opened the artery up, 1 shock, she came back and she is good to go. This is another patient that came, he's fibrillating, he is on ECMO. And there is a big thing missing here, as you'll see later. This is the LAD, this is the circumflex artery, and this is what was missing. Look how big this LAD is. It goes all the way down, keeps on going, comes around all the way to the inferior wall. So that LAD perfused probably about 40% of the myocardium. You can do epis, amios, jump up and down, pray to whichever God you want. This heart is not coming back, okay? So this is a very bad sign. When a heart looks like this is long parasternal view, and you see the aortic valve here. We have an impella. We don't do that anymore, but at the beginning I thought it might be a good idea in this case. But what you see here is the septum. The septum is about 4 centimeters wide, which tells you that this heart is basically so contracted, ischemic contraction we call it, hypercalcemic, that it's pretty much dead. And in this, let me see, this is the short axis view. There is no cavity. So it's all muscle that has a cramp, like your muscles cramp, which is very painful when you exercise on your calves, right? And this is what we are afraid of, is brain edema or ischemic anoxic injury, which this is basically, gray, white matter cannot be distinguished with each other. It's like a mush, right? And that leads to this, which is nuclear scan evidence of brain death because there's no update of radiotracer in the brain. You see a lot of blood flow going to the nose and the mouth, but nothing in the brain. That is, you don't want to see that, but I'm not going to show you all the good stuff because we are actually traumatized by the bad stuff. And I can tell you there's a lot of people that are alive because of this program now. There will not be, but there's also a lot of people that we missed. And every single one of them, especially the younger ones, has taken a piece of us, right? So this is a 53-year-old woman that has no normal coronary. So that happens too. You don't find a cause. In general, if you don't find a cause that's readily reversible, that's a bad sign. Young women with no coronary artery disease tend to do the worst, and I do not know why, but that's the way it is. I mean, it makes sense. There must be a reason that a young woman has cardiac arrest, refractory cardiac arrest, and does poorly, right? There's something fundamentally wrong that most of the time we don't know about. So this is a 44-year-old patient with refractory VF and 53 minutes of CPR before ECMO initiation. And so, I don't know what's happening. Something is happening. Let's see. I know it doesn't show, I'm sorry. So this is another case. So just to be clear, what time are we okay? Yeah. Okay, so the repercussions of having expertise in resuscitation can be transformational in a healthcare system. So this is a colleague of mine who treated a patient with a heart attack in a different hospital. She went in and she had aorobifemoral bypass. She had inferior STEMI, but she has received half a dose lytic by EMS crew because of a bizarre protocol they have. And the interventional cardiologist refused to take him to the cath lab that night. And the next day she deteriorated. She had pulmonary edema, bradycardia, and my good friend and colleague, who was the first author on one of our papers, took her to the cath lab in a different hospital. And she finds out she has an RCA STEMI. She tries to open it up and the artery blows up and there is coronary perforation. Coronary perforation leads to tamponade. He puts a balloon up, but then she has massive RV infarct, acute deterioration, PA arrest, and they're doing PA arrest resuscitation, puts a drain in, and still PA. He calls me on my cell phone. I was going into the movies with my son. And says, I need ECMO. I said, okay, but do you have an ECMO machine? He says, no, we don't. Well, I said, how old is this lady? 60, and this and that. And pH is okay, and LCO2 is okay. And when we give epi, the right ventricle squeezes, and we can have some pulse, but then that's not sustainable, goes away into PA again. So basically, we activate the VF protocol. This was a witness patient. We knew what the blood gases are. We knew what the problem was. So she gets on Lucas, gets into an ambulance with going CPR, transferred to my hospital, put her on ECMO, and that's what she has now, okay? So this is an osteal RCA disease, and you can see here that the artery has clotted. So there is a clot. But this is a nice cannula. At this point, her blood pressure is normalized. We control all the blood gases and lactic acid and all these things. And I'm able to wire that clotted artery, perforated artery, and it's beyond the point. The point is that I was stented everything, and she had an inferior right heart that was functional again. And 1 month later, her EF is normal. I don't know if it can play. I think it can play. Okay. So are there any cardiologists here? Okay.
Most of ours go this way, right?
And this is the inferior part, right?
I don't know that. I'm going to hear Mr.
Okay. You're a cardiologist, you should know that's an echo, right? Okay. So, but effectively what I'm showing you is that the heart, the injury of the heart is reversible, and I'll make sure. But that's what we're afraid of. So this lady, 1 month later, still is unresponsive. So you'd say you're very happy right now, right? I was very happy. We did something good. But this lady is unresponsive, and that most of your cardiologists are going to say, "Where's the evidence these people will survive?" Right? Correct. So the point here is we don't know anything. And the reason we don't know anything is because we have already predetermined ideas about what is appropriate and what can be done and what cannot be done. I'm not saying there is, like if somebody has a herniation and brain severe injury, it's over. And we actually don't admit these people. But this injury, if you look at it, you'll say it's really bad. The neurologist said it's very bad. Numerous foci of involving infraction in the cerebral and cerebellar hemispheres, yada, yada, yada. You read that like, why did I do all these things, right? And I was ready to declare her dead or withdraw and put him on comfort care. But once the infection was treated, this lady wakes up the next day and she started talking to us. And she's a nurse, and she is now 1 month after, and she's walking in. Her tracheostomy has healed, and she's good spirits and does everything she wants. She's a retired nurse, and she's very happy to be alive. And we had to go through the grafts, which I've never done before. So it's, now you'll say it's a case of one. It's not a case of one anymore. That's the bottom line, right? So this is, though, very important, coming back to my discussion of what can be done in the cath lab does not really reflect the program. You can have the most skilled interventional cardiac surgery person in the world. If your EMS doesn't give you good quality patients and they do a good job and they don't expedite the transport and they don't have a communications protocols with you, this doesn't go anywhere. So this is a patient with blood gases on arrival. It says arterial. PCO2 of 103 and PO2 of 28. Anybody can tell me what that signifies? Acidosis and hypoxemia. This is effectively not ventilating. It's asphyxial blood gases. You know why this is the case? Because a lot of those patients don't get endotracheal intubation. You'll see now endotracheal intubation is not any better than supraglottic airway device JAMA paper, right? And then you think about those things. All these JAMA paper patients, what did they receive for that duration of CPR? Nothing. Their survival rate was 4%. What will make better 4% survival rate? Nothing. You think the intubation is? No, this is going to make it better. But that tells you that this population who receives continuous CPR for 60 minutes and you back ventilate during a compression, who do you think is going to win, the machine or your hand? The air does not go in. So effectively you're ventilating either the gut or comes out. Intubation helps in these cases, and also what helps is changing the continuous compressions to 30-2 when you start transporting somebody. Why? Because you have dedicated time to perform ventilations, and the reason we need circulation, back to the basics of medical school, is because we need oxygen to reach the tissues. Circulation alone after 40 minutes of CPR without oxygen doesn't do anything. Actually probably does more harm. Okay, enough of the blubbering, but okay. It's a sensitive issue because it's very hard to making people understand that we need oxygenation. So, and then all this is great, but then what happens after we put them on ECMO? These people are very sick. And if you want to do something like this, and I say that all the time, you need to train. You need to create a program that a few people take care of them to get the experience and what it needs for these people to survive. ECMO is a small part of all this, okay? They have severe brain injury, they have myocardial dysfunction, ischemic perfusion injury, and persistent precipitating pathology. They have a lot of complications, traumatic, iatrogenic, bleeding, infections, and this is what you expect. The reason we were successful with our survival, and now I changed all the ideas, is a question. How long do you think is the average withdrawal time in the United States for people admitted post-cardiac arrest in the ICU? Any ideas? 3 days? Very optimistic. It's less than 2 days. The majority of the people in the hospital in the United States are see that little thing down there? So that's important to understand. Less than 2 days. They don't take the time to allow them to survive. So ECMO cannulation, less than 5 days. Decannulation. These people are on ECMO support for 4 days. Not alone, not unlike the respiratory. If you're ICU guys here or you do ICU rotations, respiratory ECMOs can be like a month, right? But these are not the case. Then ICU transfer, meaning they are moved out of the ICU. On average, about 10 to 12 days. These are long stays. They have a lot of disease. And following commands, it can take up to 2 weeks, and the majority, 22 days. All right? So that doesn't say that I know what the limit is and we cannot do things to expedite that. But that's the state of the art of post-resuscitation care. Most of the people in the United States will be done here. Now, cause of death. The majority, I'll go to this one, sorry, it's easier to see this one. This. The majority of brain death happens early on when there is herniation, and then there is brain death subsequently. And the probability of survival, as you see here, decreases within 20 days. So if you start waking up within the first few days, you are very good. And within the first 5 days, we see the majority of the patients. If you are able to wake up at day 3 or 4, that is a good thing. You are definitely going to survive. But if the patient, every day that passes, after 2 weeks, the probability of waking up is small. An oxygen brain injury is important. Brain death is very common. The first head CT is a critical part of all this. So after the ECMO, they go through the CAT scan, go head, abdomen, and pelvis. We look for bleeding, very common, spleen lacerations, liver lacerations, a lot of thoracic pathology with hemopericardium, pneumothoraces, mediastinal bleeding for the cardiologists and surgeons because of the traumatic nature of CPR for that long. If you do have seizures the next 48 hours, especially if you have status epilepticus, that's a very bad prognosis. These are not new, this is already known, but it's post-arrest myocardial dysfunction. The first 2 days, 3 days, heart doesn't exist. Even if you're able to get, after 15 minutes, somebody's pulses back, you admit in the ICU, I can guarantee you within 4 hours, residents, when you have residents, fellows, when you have fellows, colleagues, when you have colleagues, will be calling you and asking you why this patient has epi, vaso, norepinephrine, dopamine, you basically baptize them in inotropes and hopefully they survive. They don't. Once you get to that spiral, they're dead. There's no way you can recover from that. And we know that. People that have brain death, and that means that they have suffered more long-term ischemic insult, they tend to have much higher use of vasoactive medications. And the blood flow runs much higher compared to people that do very well. Cardiac recovery, that's what I was telling you about. Within 2 days, the F is less than 20% and then recovers almost to normal within 2 weeks, despite that horrible coronary artery disease that was present. That's the remarkable thing. So they can imagine the majority of these people were walking, doing regular activities, they never complain to their spouses or friends, and they drop dead. They go back to where they were. The heart goes back to where it was. It's a muscle. It's going to recover. Lactic acid, as I told you, clearance of lactic acid has been described also by Mike Donino in Boston with a trial that if you don't clear lactic acid, you tend to do bad. Liver function, not a lot of differences. Renal function, if you have renal dysfunction or you're on dialysis before, obviously it's very bad. Few people, no survivors require hemodialysis, but 2 survivors received hemodialysis temporarily. So we haven't anybody who had so much damage that before was normal kidney function and then kidney function or kidneys recover. I mean, you can take this organ, play soccer with it, and then transplant, and it's going to survive, right? It's a very resilient organ. So infections, very common. Pneumonias are very common. And then culture positive in half of the patients. Pneumonia is 44%, bacteremia 9%. And then on top of that, you have the complications. I just want to, the reason I'm showing this is not ECMO. It is EDECMO talk, but this is no ECMO. You need a huge team and a lot of expertise. Rib fractures, very common. Lung injury, 83% in people that die, and everybody here, 75% lung injury. Pneumothorax, bleeds, abdominal bleeds, pancreatitis, RP bleeds. It's a lot of disease. And then, after you admit somebody, you need heroic measures from your surgeons, critical care team, cardiologists, because things happen. Like this guy here was 93 days in the hospital, had ischemic leg, we had to do central ECMO because his heart wasn't already, and then he survived all this, and then he had ischemic gut. So he's, had some surgery done, and then he had to survive this, and now he's sailing and back to his normal life. But if the surgeon would have said, well, I'm not touching this guy because he had cardiac arrest, I'm not going to relieve his ischemic gut, he would be dead, wouldn't he? So the mentality is changing. And the take-home, multi-organ failure is profound, but transient in many cases, not all of them, and recoverable in a reasonable proportion. Traumatic complications are related to prolonged resuscitation, but in my experience is that they are not life-threatening in the majority of the cases. They survive. Neurological injury is the main cause of death, and we need to find better ways. And these are the people that are with us today. This is the first lady that had 2 hours and 20 minutes of CPR and had the LAD dissection. This is one other guy that had the coronary artery disease, survived, and he still owes me that fish. This is our first patient, and this is a 26-year-old that had WPW, he had VF, 70 minutes of CPR, his lactic acid was 20. Would you let this guy go? Because my protocol said 18. I couldn't come to terms with it because I really didn't have a great explanation for his, and he's also a bodybuilder, so his lactic acid production was higher. So you kind of have to use your mind, and you know, he's there. He's back to dental school, and he's great. The other guy I showed you, and his wife have become good friends, and they come to our events. And this is where we're going next, and I'm finishing very shortly. It's called the Minnesota Resuscitation Consortium Next Steps. So we are going to have almost a statewide coverage with collaboration with different EMS, and create a team of select physicians, nurses, and paramedics that they will be owned by all the healthcare systems. And our goal is to provide that lifeline within 30 minutes. So no more fighting about these 300 patients, where they go, why sealing my patient. That needs to stop. The expertise and the infrastructure as needed to treat this patient population because of the time constraint needs to be centralized and needs to be shared. As you have SWAT teams, or you have firefighters, everybody goes with a little, hose to try to, you ask the firefighters to do the job. Everybody can put a little fire out, but these are fires that are very, very big. And if you don't know what you're doing, and if you don't have the infrastructure, the cost is tremendous to do it unless you share it. So that's where we're going. We hopefully will be operational by the beginning of 2019, at least in the larger metro area, and then subsequently have mobile emergency departments on wheels, and then chase vehicles to go to the closest ED, and we have algorithms that will allow us with a lot of clarity for the CEOs of the hospitals where the patients go to optimize their time, not the healthcare system's interests. So obviously we are not the only ones who are doing this, and there are 5 important studies that have been published. There's the CHEER trial in Australia, small but important. A lot of Japanese have done this, and then the Paris, I'm only quoting period 2 because I think that's the only one that can be quoted, with a reasonable survival of 28%. They have different problems there because of traffic, very large difficulty getting to the patients up in small stairways and this and that. So they really have to move the ECMO to the field. I don't know why they do it on the streets. They could have an ambulance that can do it instead. That's what we're going to do. But they have done better than they were before, so it shows promise. The concept of bringing the ECMO to the patient is their idea, and they need to be credited for that. We have done 148 cases so far, and we do have 42% neurological survival. But there is no doubt that we have to be able to perform all this within an hour. And there is only 1 hour, really, that you have the chance to save somebody. After that, things drop very quickly. So this is a proposed changing of guidelines, creating a new continuum for acute coronary syndromes. Cardiologists might start throwing things at me now here, but it's actually going to be hopefully coming out circulation as a statement. This is ambulatory patients with unstable angina, non-STEMI, and STEMI. And this is the probability of coronary artery disease versus the survival rate. And this is unstable angina, non-STEMI, STEMI. And you see that probability for unstable angina is about 40%, non-STEMI a little higher, with STEMI about 80%, and survival 98, 99%, and 96% to 95% with STEMIs. And this is based on published randomized trial data. And this is what we have for out of the hospital VF-VT patients with positive pulses ROSC in terms of then circulation, and they have no ST elevation in EKG post and STEMI on EKG. The probability of coronary artery disease in non-STEMI post-VF is the same as in stable angina. Survival is less. This is what the ACCESS trial is about. So you figure out if these people need to go to the cath lab early as a STEMI equivalent. If they do have ST elevation, the probability of coronary artery disease is higher than the STEMI with ambulatory patients. And if they don't have pulses, they have refractory VF based on our protocols, the French protocol, our protocol, Japanese studies, and the CHEER study, the probability for survival is about 40% altogether. But the probability of coronary artery disease is about 85%. And if you don't have that, you're below 10% chance to survive. So ECPR programs are far superior so far, and we, this summer, will start the RS trial, which is only going to address the issue, do you need ECMO to go to the cath lab or you need pulses to go to the cath lab. We're waiting from NIH, and it's going to be done in 2 years. It's small, it's 180 patients. Questions? Yes?
How do you modify your antiplatelet therapy after angioplasty in the patients who've had prolonged mechanical CPR?
We don't. We give the same dual antiplatelet therapy that we give for our STEMIs. And we just, if they have traumatic issues, we decrease the ACT and we run higher flows on the ECMO. So the dual antiplatelet therapy, we don't use Plavix because it's not absorbed in these situations. We use Brilinta. And if patients don't have NG tube immediately, we can give Cangerel IV, which is very expensive. We don't prefer it, but we use it if we cannot give down Brilinta. There's aspirin, Brilinta on board, and heparin. By heparin, we give the ACT to about 180 to 200. And if they have bleeding complication, we drop to 160. And we try to go a little higher flows.
It looks as though you gave so much data. It was an excellent talk. Thank you very much. It looks like you focused on out-of-hospital arrests, pretty much. How does your in-hospital arrest data compare with your out-of-hospital arrests?
I don't have in-hospital cardiac arrest data. I don't have very few people in VF in the hospital.
Okay.
So I don't take people non-VF into the cath lab.
Okay. That's unusual because I think that there's, we've done this for 30 years and we have a lot of in-hospital experience. I also noted that if I saw it correctly, that your mean age was in the high 50s?
Yes.
So this is a very selected population opposed to our average in-hospital patient is 80, and so it's a different group. Could I ask some?
It's not a, first of all, just you make a statement. It's not a highly selected population. This is the population that arrests out of the hospital.
No,
the average age is 62, but because we cut off at 75, the mean comes lower because we don't take the 80s.
Right.
So it's not a selected population. Is age defined like cardiogenic shock,
Yeah.
right? All the studies were done up to 75. We use the same criteria to go to the cath lab.
Right. I think a lot of times our data, we lump in-hospital arrests with out-of-hospital arrests, and those are different patient populations.
That is for
and
sure.
the out-of-hospital arrest, what drives your EMS system to get someone in is very different if they're 85 versus if they're 50 or 25.
No, that is protocolized, so there is no
is.
individualization of those
It is.
protocols, right? Yeah.
Could I ask just some functional things?
Yes.
How do you do your distal perfusion on your arterial limb side?
Yes, I can show you this. So we.
I mean, what's your preference?
Yes, I think usually a picture is worth 1,000
Okay.
words, right? I can show you what I use. I do not. People used to use regular sheaths for coronary angiography and put them distally. We found out that we spend a lot of hours with patients on the floor trying to deal with kinked sheaths and clots and distal. So I use a 9 French dual lumen MAC sheath. And the reason we do that is because we use the one sheath for the flow to go down, which is unimpeded because it's end-to-end connection.
Sure.
And the other side we use for heparin systemic anticoagulation. So our heparin systemic anticoagulation happens in the distal perfusion in the distal perfusion port. So this is what we use. Most of the people do this, and we do this. So this is basically goes with micropuncture, ultrasound guidance into the into the superficial femoral artery. Then we put this catheter in. This port, I don't know which one is which now, but one is a bigger tube. I think the brown is the one which is bigger, and it can be connected to this large tube, right, from the ECMO. Instead of going through this stopcock, it goes directly end-to-end connection here, and you have very good flow. So flow is good, and then through the side port, we use drip of heparinized saline.
All of your heparin for the patient goes through your antegrade SFA. Do you do any retrograde DP or PT perfusion?
No. Well, I have only seen one patient that had the distal peripheral vascular disease that was so severe that we needed to do something like that, and we did with the vascular surgeons, yes.
You can percutaneously access that with that 8 wire-wound arrow, and it's a wonderful job, and it saves your surgeon from having to go down and dig out that distal SFA with a counter incision. My next question is, how do you decompress the left ventricle during support?
I don't.
In someone you never do?
Never have.
You had 75% incidence of pulmonary dysfunction, and you don't think that a high LA and LV EDP contributes to that?
There is no EDP on ECMO. There is no flow through the ECMO.
That's
and
not true. No, you get bronchial flow, and we see it all the time. Pulmonary edema with very high wedge pressures in a heart that's not ejecting.
Well, I can tell you my experience. I've done 145 cases. I have put 120 ECMOs post-cardiac arrest. I haven't seen a single patient having requirement for LV dysfunction. So we never decompress. If there is AI, the patient is dead. You cannot put him on ECMO, right? So that is something that we've seen in the case of PEA where the valve was open. These are not chronic disease patients. Even with people that we have found out afterwards, which a small proportion, they had LV function less than 30%. These people came off on ECMO day 3 or 4 or 5, and they were back up to where they were at EF. So, is it possible that we won't be able to decannulate somebody because of that? I hear all the time, and I call that my personal experience does not support any of that statements.
We don't share that experience because we've had many patients with florid pulmonary edema in a barely contractile heart with wedge pressures of 30. And we needed to balloon septostomy or drain the pulmonary artery.
In your case, though, so you're a cardiologist, right?
I'm a cardiac surgeon.
Surgeon, okay. Cardiac surgeons have a very different feel about this technology because they use it for hearts that actually work.
Yeah.
For us, there is no EF. The RV is dead for 2 days. There is no pulsatility. And actually, we cannot even do pulmonary angiogram on ECMO in these patients because there's no flow through the pulmonary artery. So, because the heart function is so weak for the first 2 or 3 days, there is no flow through the pulmonary gradient, circulation.
Bronchial flow is 1 to 3% of the total flow, and the venous cannula, in our experience, never captures all of the right heart. Now, you're right. If the RV isn't working, it doesn't pump, and it stays in the RV. My next question is, if I read it correctly, because you had so much data, it looked like at 21 days, I couldn't tell, you had no survivors at 21 days. Well, what is your average length of ECMO support, and where do you start drawing the line? And do you have an advanced mechanical support program at your hospital?
Okay, so yes, of course. The University of Minnesota was the first program in the country that did that, but you know that, right?
Well, wasn't Lyle there?
Yes.
Yeah, I know Lyle well.
Yeah. So they do have support, and you're asking about this probably here. This is what you're asking for?
Yes, that's the slide. And
So
I
this-
wasn't exactly sure what that was.
No, this is for the probability of surviving neurologically intact based on the days that you have in the hospital. So your probability of survival neurologically intact if you are in the hospital 2 days, it's so much. And if you still haven't left the ICU, your probability of neurological survival decreases to 0 after 22 days.
Okay, and what's your average time of support for
Yes.
your out-of-hospital arrest?
There you go. The cannulation 4 days, so on ECMO 4 days.
Okay,
Commands usually 6 days for survivors, extubated 7 days, ICU transferred to average, these are averages, 11 days, and discharged 24 days.
so in your standard deviation or median, in other words, did you have a cutoff day? If you reach 7 days without cardiac recovery, will you start considering either a durable support or?
Yeah, we don't, so this is not standard deviation, this is our population, it's not as, so this is all our patients, and what you see here is cumulative data. So this reflects all our population, there is no mean and standard deviation. This is what happened to our population.
Right.
So what you see here is that ECMO decannulation happens to 5 days in 100% of the survivors. People that don't survive and they have other issues to be declared dead, obviously they stop cannulation. There's no decannulation, they declare dead. But if we have had 2 patients that got for LVADs and 3 people that went from ECPR to CABG, but we have signs of neurological recovery in the meanwhile. So day 3 or 4, they start moving, and if they had to move and kind of wake them up and see if they can respond appropriately, they went for bypass and woke up with bypass without all this.
So you have 2 bridge-to-bridges in this series.
Right, bridge to bridge, and then we had 1 patient went for transplant later.
And he was still on ECMO?
No. So they went VAD transplant. It wasn't destination.
Okay.
And then we also had 3 bypass surgeries. So the surgeons took them, despite the fact they were on ECMO after cardiac arrest, but they had, that was a big deal, I can tell you that. And then we had also 4 patients that were organ donors. So from those 4 patients, we had times 4, 2 kidneys, livers, and pancreas patients that received organs from them.
Okay, thank you.
Fantastic talk. I just want some clarification on the people you withdrew on because they didn't obtain a perfusible rhythm in those 90 minutes.
Yeah.
So if you had someone, you did PCI, they haven't even had their CT yet, but they're still in VFib or VTAC, or at that point you're going to withdraw?
Yes.
How?
I just stopped the ECMO then.
Right. So, and then ostensibly if they got pulses back, fine, but if not, then we're declaring them dead.
Those people who withdraw is people that don't even have an organized rhythm,
Right.
Like there is no EKG is still asystole.
But
So
would
if
there
you stop
be-
the ECMO, there's never going to be a
So
pulse.
asystole, that makes sense. If they're VF and VT, you're still stopping?
No. There is no one after 90 minutes that you're talking about VF that cannot convert.
Right, so refractory VF.
Yes, only had 1 patient like that. That we bring him back shock on ECMO. He'll QRSs and then go back to VF. We give beta blockers, we give anything we could, but 90 minutes, that's the only patient that we have like that. The majority of the people that we do is because they didn't have any EKG at all, 0.
But what if you had another one at this point? Would you withdraw if they were VF or only asystole?
I'm not sure I understand your question.
At the 90-minute mark, post-PCI,
Yeah.
they're still in VF.
Yeah.
Are you withdrawing? Or are you
Yes, I am
continuing the ECMO
withdrawing.
run?
If they cannot have an organized rhythm after 90 minutes of normalization of flow, pHs and all the metabolic milieu over there, we withdraw. And the reason for that is it's always a battle between admitting patients that are going to die in the hospital as an inpatient status. And so we wanted to make sure that we give the best chance for the program to be successful. I don't know if that's the right way to do this, but that's what we do.
Do you want to? Jim wanted to ask a question.
Outstanding work, really. You noted that it seems like the patients that do poorly are relatively young women who have clean coronaries. Now, my first is, are a lot of these massive PE patients, or what?
So that a little bit answered the question. Oh, sorry, what was your name?
Rob.
That's Rob's question. So that's how I know that there is no pulmonary artery. So many times we have to do pulmonary angiograms in the cath lab on ECMO. You can't. You can go up to the pulmonary artery, you can inject, the dye doesn't do anything. So we have to clamp the ECMO and do CPR to see where the angiogram goes. And so No, these women didn't have massive P's that we could identify. In post-mortem, in a couple of them, most of them don't want to have anything done, but in a couple of them we didn't see anything. So I don't know what the answer is.
Do you have tox screens on them by any chance?
We do, all of them get tox screens.
I've had some women like that that have had reversible myopathies from marijuana.
Yeah, there's a lot of that going on.
About 4
So,
days,
yeah.
and then their hearts come back.
Last thing here, this slide is, I think, so good for us, and there's so many good things that you mentioned, but one of the things here that I'm interested in, and I think maybe we can even do better, is in neuroprognostication. You mentioned here that you've got following commands at 6 days, but that at 2 weeks, there are still roughly 60% of the people not following commands.
Yeah.
How are you organizing this? Are you getting neurologists involved? Who are making these decisions, and how are you deciding that? Because that is the endless question for us.
So this is, it's recorded, right?
We can cut this out. You're much.
No, the answer to this is you have to ask yourself, what knowledge does really exist that will guide any of the subspecialties to make a decision? Notwithstanding the very obvious badness of neurological devastation if there is, severe edema and herniation. So what we've done is all these patients under our service. So I basically had all these patients under my service 24/7 for 2 years. Now we expanded with 3 people that they went through the program, and we have a team that only that team takes care of them as a primary team. Now we consult with neurologists. Everybody gets EEGs, and we have the neurologist and neurointensivist come to help us manage if there is brain edema. But when there's brain edema, we basically withdraw, get a nuclear scan, withdraw, and then that's it. There is no neurocritical care management of this patient. Now, it doesn't mean I cannot be tested. Can you do craniotomies of these patients and let the, the answer to your question is the appropriate teams have been consulting on these patients, but everything goes through one bottleneck, which is our service. Because the other thing that I found was very difficult to handle was the communication with families. Now, we had 20s and 30-year-old patients and 40s and fathers of 2-month-old and mothers. These are not easy discussions to have. And therefore, I realized that everybody was coming and bringing their own biases of any specialty, and I didn't want that to happen. I know it sounds a little bizarre, but that's the way it is, because I would have an assistant professor of nephrology go in and say, I don't know why you guys even want to do dialysis. This is a dead patient to the family. I should never do that again, I can guarantee you. But the reality is that's what you have to deal if anybody can have this communication and say those things to the families. And so over time, when you build a program like this, in any, neurocritical care developed because there was a need for it. Cardiac care developed because there was a need of it. It actually came because of the MIs, and then when cardiac surgery came in, they needed dedicated expertise for this. I don't see why you expect generalists to take care of this population, which is so specific and so highly diseased. Burn units became, because of that, to do specific disease. And people develop expertise to treat these patients. It's the same situation here. Nothing different, nothing less, and nothing more.
Okay, well, hey.
Thank you.